Morning. My name is Chris Kempton, and I am the Director of New Business Development at Walsh Duffield. I'd like to thank you for joining us for today's webinar titled Benefit Trends, State of the Marketplace, presented by Mike Conroy. Mike is the Vice President and Group Benefits Director here at Walsh Duffield. We are happy that you were able to join us today at this as this webinar kicks off our 8-week summer school series, where we will be hosting a different subject matter expert each week to discuss some of the hottest topics surrounding insurance, employee benefits, and challenges we are facing due to the pandemic. If you haven't checked out the rest of our lineup, be sure to visit walshduffield.com/summer school for a description of each presentation and for the links to register. You do have to register for each course separately. Before I introduce Mike, I would like to cover a few housekeeping items. Today's webinar is being recorded. We will share a link with you after the event along with the presentation slides. This presentation is approved for 1 SHRM professional development credit. We will email the code needed for this credit to live attendees after the webinar. Also, we invite you to comment and ask questions. Please use the Q&A box on your screen. If you think of a question at any point, just type it in the box and we will hold it for the discussion portion at the end of the event. And with that, I'm happy to introduce today's presenter, Mike Conroy. Mike joined the Walsh Duffield team as Vice President, Director of Group Benefits in late 2020. Mike comes to Walsh Duffield with over 24 years of insurance experience, both on the carrier and broker sides. He has spent time at Independent Health and at Blue Cross Blue Shield, and most recently was the Director of Group Benefits at M&T Insurance Agency. Mike's industry experience, analytical skills, and local leadership adds a foundational strength for our group benefit clients. Today, Mike will be discussing benefit trends and the state of the marketplace. The pandemic has unquestionably reshaped the benefits industry over the past year and a half, teaching us significant lessons along the way. But what does the future hold? In view of this uncertainty that still exists in our workforce, there are many employee benefit considerations for those in the HR and leadership. At this time, I'm going to hand the floor over to Mike, who's going to start today's presentation. Mike, it's all yours.
Chris, thank you very much. Yes, 24 years experience in the business. I think, I probably have met almost everyone in West York at one time or another. I spent 6 years with Independent Health, as Chris mentioned. Spent another 13 years with Blue Cross Blue Shield, and then been on the consulting side for the rest of my career. So, when I look at the West York marketplace, unfortunately, I'm starting to look a lot like a history book. When I was thinking about the topics and they approached me on, market trends, there's a lot going on. And certainly, first, I want to make this an enjoyable presentation. So I thought, what topics really maybe people aren't front and center on, but are pretty interesting and showing trends that, it could be here sooner than later. So one of the things I wanted to talk about was there was recently some a bill at the New York State Assembly and Senate looking at the New York State single payer system. Then I do want to touch on reference-based pricing. And I don't really want to sell reference-based pricing. I think a lot of people have seen presentations on reference-based pricing, and it's always a sales pitch. I really want to talk about the concept and really how we got to this point. Then I'm going to talk about the Consolidated Appropriations Act and how that actually impacts healthcare, how it impacts employers that provide services and benefits to their employees. And then finally, there are some interesting things going on locally here that I think is going to make 2022 a very interesting year And coming out of COVID, it just gets amplified. So some pretty interesting things going on. So the New York Health Act, I'm amazed how this wasn't mainstream news. And a lot of people were even unaware that it was going on. So really, there was a bill that was introduced that would move New York State into a universal single payer system. No other coverage could be offered. It would be one plan mandated, managed by the state. You know, the way that it's designed, it would eliminate all out-of-pocket costs, network restrictions, and this would eliminate insurance premiums, and it would be financed through payroll taxes. So it was co-sponsored by the majority lawmakers in both the House and the Senate legislature. So leading up to June 10th, you know, the thought process was this has a very good chance of going to the governor for approval. As mentioned, it would just completely transform the system we know now. And, you know, and it would then, whoops, sorry about that, showing my challenges here. And it would basically be paid for by a progressive payroll tax that would be paid by individuals that are making $25,000 a year and up. So let's talk about this here a little bit. So the supporters, as you know, it had support in both the Senate and the Assembly, you know, and the logic was that it's paid for fairly. And before I go on to talk about the supporters and the detractors, I do want to say I'm taking politics completely out of it. I'm just basically telling you what the supporters liked about it and then what the detractors liked about it. So this does not represent a point of view. But the supporters like that is paid for fairly. You know, costs would be fairly distributed. And one of the examples they gave was a big successful company pays less than a small new business. Comprehensive coverage. All New Yorkers, regardless of immigration status, would be covered for all medically necessary services, from primary care to prescription drugs to hospitalization. There would be no network restrictions. Only patients and doctors would be making the healthcare decisions. Interestingly, too, projected cost savings. It eliminates insurance companies and provider administration from dealing with insurance companies. The state could leverage pharmaceutical contracts and equipment prices. Property taxes would be reduced because local governments would no longer have to pay for Medicaid. And the RAND Corporation, which is an independent analytical group that helps support politicians in government, they estimated that over the next, by 2031, health costs would be 3% lower. So there was actually some financial data too that supported that this is going to save money. Now let's get to the detractors. And this, I had to go back and read this a couple times. The funding of it would require $139 billion to $226 billion in new tax revenue per year. To put that in perspective, that's about 150 to 200% increase over the projected total state revenue tax now in the status quo. So it would dynamically change the tax structure here in New York State. Obviously, premiums would be gone. So that's the balance. The detractors also said the progressive tax on residents would also drive high earners out of the state. And as more high earners left the state, the cost burden would be handled by lower paid employees, middle class, and you know they pointed to that it's not sustainable. There was also estimated ranges that could cost upwards of 300,000 jobs in New York. You know, 50,000 related to the health insurance industry, 110 in the financial services, another 125 in other high income professions, and 30,000 leisure and hospitality industry. So their concern was you're driving a lot of jobs out of the state. There is a huge question too, to make this work, everybody has to pay in. Now that's a problem because you're basically Medicare, all the Medicare Advantage plans would cease to exist. Anyone that is on Medicare would have to go into the state program. And then of course, all self-funded programs would have to cease. And you know, self-funded plans are not governed by the state, they're governed by ERISA, which is federal. And just to give you an idea, 1/4 of New York State's employees are covered under a self-funded plan. So there's a huge question if you can make those two even legally go away. There's a thought process that you cannot. So, and without those two populations being in the program, they're saying that it's not sustainable. So where does it stand now? Interestingly, this legislation was first introduced in 1992. It's been on the cusp of passing for years. Now, the bill's actually passed in the assembly 5 times. So, there's a lot, if you go and research this, there's a lot of articles leading up to about June 7th or June 8th about the benefits, about, the negative factors. Interestingly, after the legislature adjourned on June 10th, it's very difficult to find almost anything on this and what happened. So, when you look at it, it was really the first time that, Democratic co-sponsors on the bill passed in both Senate and Assembly. It is opposed by labor leaders, businesses, and insurance executives. So the supporters and detractors cut across political lines, and it's opposed by Governor Cuomo. So what really happened here is it just never got to a vote. And Democratic leaders blocked the vote under pressure from labor leaders and insurance executives. So many unions feel that if we're going to do something, it needs to be done on the federal level, because you don't want New York State to stand out. And if it goes poorly, it's going to cause more business to leave the state. Interestingly, though, on a national level, typically labor also opposes a national solution. Without saying it, I believe a lot of politicians agree with the concept of a single solution, but there's just too much unknown on the impact on overall costs, taxes, how it would impact providers, jobs, quality of care for them to feel comfortable to move ahead. Even the RAND study, you had a lot of assumptions built into that. And if those assumptions don't come to fruition, like let's say the self-funded plans don't have to come in, then you've got a funding problem. So I think there's still too many unanswered questions here. The one thing I can guarantee you is it's going to be front and center every year. To make it this far in 2021, there's really no reason to believe that it won't be front and center in 2022. So it does bear watching. But like I said, it's not something that got a lot of headlines leading up to it. But if you're following it, it was a pretty intense conversation. So why did they look at a single plan solution? It's costs. I think we all know that. The industry has not done a great job of controlling costs, and it's forcing businesses to out of business, reduce workforces. It's killing our innovation as a country. So that's why healthcare is front and center. And that's why states are desperately looking at things like, okay, should we go to a single solution? One of the things individual companies are doing, they're looking at something called reference-based pricing. And today, I don't want this to be an advertisement for reference-based pricing. This is just strictly educational, just to give you a feel for what it is, and candidly, how did we get here? Because I think there's an excellent example right here in Buffalo that's happened in the last 20 years that tells us a lot about how we got to this point. So what is reference-based pricing? In a nutshell, it's a company taking control of what they reimburse providers. Right now, you deal with a carrier, whether it's an Aetna, a United Healthcare, a Blue Cross Blue Shield, Independent Health, MVP, CDPHP, Univera. We know all the names. And you rely on them to negotiate on your behalf with the hospital systems, with the providers. And companies are starting to take a step back saying, we don't like what's happening there. We think we can do a better job. So they basically come out with a model, and this is on a self-funded platform, that they say, we are going to pay this fee to this hospital. We are going to pay this fee to this physician. That's pretty complex, and it's really different. There is an article in Forbes. It was first put out there 2016, and it does talk about the why. PPO networks perpetuated the greatest heist in American history. That's what the title is. Now, I will say this about the article. It's a very good article to read. You have to take it with a grain of salt, because the expert that's quoted in it works for a reference-based pricing company. But basically in the article, they connect the loss of the middle class in America to PPO networks, and more specifically to the lack of transparency in the provider reimbursement model. You know, the carriers go negotiate with the providers, they determine a fee, then they determine a premium, and the end user gets the premium. And as we all know, that premium's been going up 5 to 6% a year. On average, I know there's people out there saying I've gotten 10, 12, 20% increases, but on average, 5 to 6% a year, like clockwork, almost since I've been in the industry. So I will say this, you know, before you read the article, it takes a very cynical view on insurance carriers. And insurance carriers certainly have a lot of skin in the problems that we have in today's healthcare. But it does make the accusation that insurance carriers want costs to rise. I will tell you, I spent 20 years with Independent Health, Blue Cross Blue Shield. I know individuals at United, Aetna, across the whole spectrum. No one ever had a conference saying, hey, how can we get costs up? But I will say this, has there been a strong enough incentive for carriers to challenge providers over the last 20 years? And I would say no. And I'm going to give an example on this. And if you've been in the business, if you've been in the West York marketplace as long as I have, you might remember this. I was working for Independent Health at the time. I was right in the middle of it. The Catholic health system had merged together. They were separate hospitals in 1998. And in 2000, a dispute came up between Independent Health and the Catholic health system. I don't want to talk about what the dispute was about. There's different sides, and candidly, it got very murky. But what happened was the Catholic health system announced on October 4th, 2000, it was going to terminate its contract with IHA, and they did it very publicly. And of course, back then, everything was community rated. I would say probably 65, 70% of the marketplace was January 1 groups. And it was on the front page of the news. It was on radio shows. I don't know if anyone remembers Sandy Beach. He talked about it every day. So the dispute played out in the court of public opinion. It was extremely disruptive to the marketplace, who was trying to make annual decisions. The thought of Independent Health not having the Catholic health system in the network, that was a problem. Well, fast forward, in late November, I think early December, believe it or not, I couldn't find a lot of information about this. I lived it, but there's not a lot. It's not easy to find articles on this. They settled on an agreement. But by then, open enrollment was pretty much over. Independent Health lost about 10 to 11,000 members just because of the political dispute, which went public. There has been disputes between carriers and providers since 2000, but nothing of this magnitude. Carriers and providers know that this type of dispute isn't good for anyone. So basically, everyone at the negotiating table has lost leverage. And so what's happening is when they negotiate, there's always that feeling like we can't walk away from the table. And what that's done, and it's been considered across the country, that that has led to higher costs because there's not this competitive environment because everyone's too worried about whether it's a provider losing revenue or a carrier losing membership. And I really find it fascinating that we've had these massive increases year after year over the last 20 years, and we've never had a very public dispute between a carrier and a provider along those lines in that time period. So, and at one point, and I'm going to talk about how reference-based pricing works in a minute here, but this blurb at the bottom here is interesting. This was the Kaiser Family Foundation put this out, that commercial insurers pay nearly double Medicare rates for all hospital services, about 200%, ranging from 140 to 260. That is a direct result of this dynamic I just mentioned exists between carriers and providers. And the question is, how did it get so far? And that's what employers, when you think of reference-based pricing, they're looking at those numbers. They're saying, why do I have to pay 200% of Medicare when I should be able to pay 150% of Medicare, 140% of Medicare? Because keep in mind, Medicare, that isn't growing as fast as inflation. Commercial insurers make up 31% of the revenue going into these hospitals. So they've got to get more out of the commercial plans than their Medicare rates. But companies are saying, okay, we'll pay more, but we're not going to pay that much more. And a real key here is your network may or may not include doctor network. So some people take a doctor network and they have doctor network, but they just have reference-based pricing for hospitals. You determine what metric you're going to reimburse on, what level, typically off Medicare, what level on Medicare. And then you identify a third-party administrator that can help deliver the repricing. And then they also offer patient advocacy, provider negotiations, because as you imagine, if your members are going out there, they're walking in a hospital and you're only paying 140% of Medicare, the hospital might say, well, we need 200, and the patient gets caught in the middle. So you need services to help on that. So the challenges. I love this line because it's very accurate describing reference-based pricing. The first one through the wall always gets bloody. That's from the movie Moneyball. And what I mean by that is in a market that doesn't have reference-based pricing, the first one through, the first time the providers see it, they're going to be like, whoa, what's this? What's happening in the Southeast and Southwest big time is more and more employers are going through that wall and providers are starting to deal with it. So it is working in different parts of the country. Up here in West York, it would be a challenge. The other problem is identifying an acceptable reimbursement level, because you're going to come to me and say, okay, Mike, where should we set it? 140, 150, 160. Well, there's not enough competitive information out there because there's a lack of transparency in the industry. And then the other thing to worry about too, in the upstate New York marketplace is it is a very competitive job market. I think probably everyone's nodding their heads right now. It's very rarely that I meet with one of our clients that they don't talk about having a tough time to find people. And if you're out there with reference-based pricing and everyone is out there with Independent Health and they're out there with Univera and Blue Cross Blue Shield and copays, it might be tough to get employees on board. And the West York workforce expectations, they expect a full network. They expect all hospitals to be in the network. They want brand awareness. So this is going to be something that you're going to hear about quite a bit. I don't think the West York marketplace is quite ready for it, but I think it is coming. And some of the things I'm going to talk about in my next segment might help get us there. If people question whether this is front and center in terms of this dynamic between carriers and hospitals, and hospital systems and carriers are getting stronger, there's more mergers out there. And I don't think President Biden knew I was presenting today, but on July 9th, he actually issued a executive order, instructing the Department of Justice and the Federal Trade Commission to start enforcing antitrust laws more vigorously when hospital systems and carriers are looking to come together. Basically, what they've picked up on is, marketplaces that have no competition from a carrier or a hospital system have far higher costs than markets that have competition. The whole thought process was carriers and hospital systems would merge together, they'd create efficiencies and lower costs. That hasn't happened because they've used their leverage. Interestingly, right now, there's 10 hospital systems in the country that control 25% of the US market. That's amazing. And so it is very much on the federal government's radar screen. But that is really the environment and the dynamics, which is causing companies to do this radical approach and think about reference-based pricing. And, our market hasn't got there yet, but eventually there are going to be companies that just kind of throw their hands up and say, look, I can't keep doing this. I've got to find a way to slow the biggest expenditure, which is the claims expense. Which, it's funny how that dovetails right into what I'm going to talk about next in the Consolidated Appropriations Act, which, when it gets the headlines of the news, you read about, it's signed into law December 27th, and, it's a 2.3 trillion spending bill, combines 900 billion stimulus relief for COVID-19 pandemic. There's another 1.4 billion in spending for the 2021 federal fiscal law. But it's interesting how much of an impact that was tied to this on how it could affect employers who offer health coverage. There's some other things in there, special rules on FSAs, ban on surprise medical bills. I will touch on that. More enforcement on mental health parity. some key retirement plan provisions, and healthcare transparency. Really what I'm going to focus on mostly is healthcare transparency, because that's what we're talking about when you want to, if you ever think of going into a reference-based pricing model, you need to know what the market's paying now, and all that, it's almost impossible to put your finger on because of non-disclosure agreements, because of different types of hospital reimbursement, packaging. It's a big challenge. So in this Consolidated Appropriation Act, there actually is a removal of gag clauses in provider contracts. And that means the health insurance industry no longer should be able to hide behind, we cannot release our pricing to the Catholic health system, we can't to Kaleida or a large provider group, because there's a gag clause in the contract. Plan sponsors, they're going to be responsible under this act for referring providers to your members. And to do that, you're going to have to provide cost of quality care information and data on providers. And you can only get that from the carriers and the TPAs. So they have to provide that. It will allow plan sponsors to access de-identified claims data to share with third parties. That's happening to an extent, but I think it's going to continue to grow. There's also some other interesting requirements there, where the CAA requires group health plans to report information to the Secretary of Human Health Services and the Department of Treasury on pharmacy, 50 brand prescription drugs that are by frequency of cost, by frequency, total spending on healthcare services, any reduction in premiums. I believe that's so the federal government can start building a database. But that's all, that responsibility is going to fall to the plan sponsors. But the goal is to create a more transparent environment. And I one thing I will inject my personal opinion here is a more transparent environment can only lead to lower costs, something we have not had. So, and also, I do want to point this out. It creates new requirements for covered service providers, which are broker services and consultants, to disclose, fees from organizations just like ours. Obviously direct compensation and indirect compensation. All those fees really need to be put out there. And there's certain areas where there might be indirect compensation. I feel I've always worked for organizations that I like the fact that our goal is to disclose everything. Compensation should be a full disclosure conversation with a client. But there are a lot of indirect compensation streams out there. If you have self-funded pharmacy, that's always one piece to look at. And that has all got to be disclosed by the covered service providers. Timing's got to be reasonable. But here's this last bullet point is something that is interesting. And this really applies to a lot of these provisions in the Consolidated Appropriations Act. Plan fiduciary requirements. So you got all these great laws and legislation out there to say there needs to be more transparency in the industry. And guess who the compliance falls to? The plan fiduciary, the clients, your organizations. At a high level, you might want to start thinking about your health insurance program a lot like your 401k. There's a lot of regulations out there that your vendors and your partners need to adhere to, but at the end of the day, it's your responsibility to make sure they're adhering to. And you're going to have to report, for example, if a CSP is not meeting their requirements. So there's going to be a lot going on in terms of disclosure. Ultimately, the world that you say, Mike, what's this world look like? The way it looks is that you're getting your claims data. You understand the different reimbursement levels between providers. You see quality information between providers, something that we've been calling for I don't know how many years in high deductible health plans, because how can you be a consumer when you have no idea what each provider charges and what each provider's quality scores are? But there is an expectation that companies will be offering tools that will give pricing to their participants and quality scores. And of course, you can only get those tools from insurance carriers, TPAs. The portion of there is a No Surprise Act under the CAA which is going to cover out of network and providers that are not participating. So members are taken out of the middle. What's interesting here is if you're a self-funded plan, careful, because if there's balanced billing, you may be responsible for that balanced billing. But I also think there's some provisions in there, especially in arbitration process for providers. If you're out of network and you disagree with what the payment is you're getting from the TPA, no longer will you be able to, the goal is no longer will you be able to send that bill to the participant. You may have to go through an arbitration process. And I do think that's going to help. And I don't have the number off the top of my head. I apologize, but I want to say it was like 17 billion that they expected this one provision to reduce healthcare spending by. But I do want you to understand that it really protects participants. Plan sponsors may be, they're responsible for implementing this. And you're going to be responsible for making sure your vendors, your TPAs, your carriers, your brokers, your consultants are adhering to these provisions. So in a perfect world, and there's a lot we don't know about the Consolidation Appropriations Act and how it's going to be implemented, and there's a lot of moving parts in here. In the perfect world, this is going to create a vehicle that allows full transparency into the healthcare industry. And really, if it dovetails into something like reference-based pricing, you should be able to do something like that. The participant never gets caught in the middle, and any disputes between a provider and what you're reimbursing gets settled in arbitration. Obviously, that's a lot, and I think we're probably 3 to 5 years away from that. But it's very interesting the way the Consolidated Appropriations Act and some of these provisions play into companies starting to make decisions on their own behalf on healthcare spending, which it's amazing. I know companies that spend months on making a decision to buy a copier for $10,000, and then every month they're cutting checks for health insurance at $150,000 a month. And they really don't know what's behind the curtain in terms of reimbursement. We do audits, we do all that, make sure that the claims are being paid according to the contract. But what I mean, not knowing what's behind the curtain, is what happened at the negotiating table between that provider and that TPA or that insurance carrier. So this is something to watch closely. But the one thing I will say is you may want to start having conversations with your consultant to make sure that along the way they're keeping up to speed on this and you're going to stay compliant. Because like I said, you really need to view your health plan now more like your 401k. So the local market updates. This is interesting because we do have a few things going on in the local market that is going to be, maybe 2022 is going to be a little bit different than almost any year we've ever seen. And obviously coming out of COVID really plays into that quite heavily. So first and foremost, we actually have technically a new carrier in town, and that new carrier is Highmark. Most of you know, they're now, they've merged with HealthNow. Highmark has very good quality scores. They're a well-regarded carrier in the Pennsylvania, Delaware region, West Virginia. This is their first move into New York State. They are very diverse. They have more products, bigger product portfolio. So I think you're going to see a lot more innovation coming to the table. But how they're going to operate in the market, how they're going to price, it's still an unknown. I will be talking about community rates in a minute here, but we'll see. They have had some change in leadership there, so I think it's going to be a combination of decisions being made right here in West New York. They do still keep a local president, Mike Edbauer, very sharp man, but he also answers to the Highmark organization. So yet to be seen. I don't have an opinion on it. I'm looking forward to working with the new organization, and we are working with them now. We actually have a meeting coming up with their senior leadership at the end of August, including their senior vice president of underwriting. It's important to have that relationship. So what's going on in the large group trends? Well, I can't talk about what's going to happen in 2022 because the carriers haven't released their trends in the large group marketplace, but I can talk about what's going on now. The aggregate trend approximately is about 7.9% of the market, which is pretty high, as we can all agree on. Interestingly, I've never seen such a wide gap between what carriers are doing from a trend standpoint. Usually, if Blue Cross Blue Shield's at a 7% trend, Independent Health might be at 6.5%, Univera might be 8%, and then it flips the next year based on hospital contracts and utilization patterns. But right now, on the low end of the carrier trends, the aggregate's 5%, and the high end is 12%. That's a huge gap. But really what happens if you're in experience rate plans, it's really how each carrier has designed their model to take into account for the claim anomalies from COVID. So one carrier that may have lower trends weights their manual rates heavier. And the manual rates are basically your demographic rate. And so they're basically saying, yeah, I see the claims, but this group, based on their population, based on their industry code, really should be here. And that's what we're going to look at more. And then other ones have said, okay, because we know the claims are lighter in 2020 and early 2021, we're going to use a higher trend. So don't get too caught up if one carrier walks in and says, we're at 5% and they're at 12%, that shows we're managing costs better than they are. That's not necessarily true. It's really the devil's in the details of the model. I do expect as we get closer to 2022, more data from 2021, which everything we see looks relatively normal to like your 2018, 2019. The trends will normalize between the carriers and we won't have that large gap. And the other trend we're seeing in Western New York, I think everyone kind of batten down the hatches through COVID, and that makes all the sense in the world. They didn't want to do a lot of change to their employment in terms of their plan designs and co-payments because most of their workforce was remote and communication was critical. Funding arrangements, a lot of groups kicked the tires on different funding arrangements, but they stayed primarily status quo. That seems to be gone. And most clients we have right now are doing due diligence on everything from contribution strategy to plan design to funding. And I expect that trend to continue. One area I did want to spend a little bit of time on here because we have a pretty interesting dynamic developing. And it's in the small group community rates. And, I try not to make myself sound too ancient and too old in this industry, but I will tell you, I've gone through about 23, 24 community rated cycles. And what I think we're going to see, I probably have never really seen it this dramatic. Probably the last time I saw a membership shift, which I'm expecting this year, was back in 2000 when the Catholic health system and independent health stopped getting along. So what's going on is all the carriers have to file their community rates with the state. And then the state does review it, and they usually come back with reductions. And typically that's going to be end of August, early September. And the carriers really have no idea what those reductions might look like. But what we do know is what's been filed. And what's been filed is pretty interesting. So Blue Cross Blue Shield has approximately 65 to 70% of the community rate market right now. They've actually filed a 17% aggregate increase for 2022. That's a big number. Univera is closer to 9.7, 9.8. Independent Health has filed approximately flat. Now, Independent Health and Blue Cross Blue Shield, it's tough because all these different plan designs to come up with an aggregate number are pretty close in rates, and Univera is right in the same ballpark, maybe a little bit higher right now. But if these rate increases stood, let's say New York State decides this year we're not going to do anything. We'll let the Blues have 17 and we'll let Independent Health have flat. That means there's probably going to be anywhere from a 15 to 18% gap in premiums. If that happens, it wouldn't shock me if 30 to 40,000 members change plan designs, change carriers. When I was on the carrier side, we always looked at the number. Groups start thinking at around 3%, at 5%. Typically, if they can move, it's a foregone conclusion. If they don't have like labor agreements, if they don't have, maybe they need some type of out-of-area coverage, 5%, they're really looking at it. If there is a 17% gap, even if there's a 10% gap, I'm expecting a lot of movement, more movement than we've ever seen before. What's going to be interesting what the state comes back with. The state usually takes this as an opportunity to influence and flex their muscles on keeping healthcare costs low. And you would expect them to really push down on that 17%. Now, why are the Blues filing 17%? I don't want to speak for them, so this is 100% Mike Connery's opinion. But since they've accumulated the majority of the market, 65 to 70% of the market, you know, the community rates are not sustaining right now. You know, matter of fact, I've had a few people in underwriting areas at several carriers tell me that it's really getting to the point that if the state keeps on depressing these rates, they're questioning whether they should be in it. And obviously someone at Highmark, you know, looked at this block of business and said, this isn't sustainable. And so it's going to be interesting what New York does here. I do think New York will push Blue Cross Blue Shield down quite a bit, but your gap still could be 10%, which still means that there's going to be a lot of membership moving. If New York State doesn't push the Blues down that much, what I would expect is a lot of membership movement. And in 2023, I think you're going to see some pretty good increases out of all the carriers, you know, because it's almost like setting a new bar. So it's going to be very interesting what happens in the community rate marketplace in West New York, especially if these gaps, if the 17% is out there. I have to tell you, I think the whole block of business, at least 70-75% of the block of business is going to end up moving. It's going to be a busy open enrollment. So not good news right now if you have Blue Cross Blue Shield. But the one thing I would say is, you know, be open-minded and let's see what New York State does with these increases. So a lot of interesting things going on across the nation and locally here. So at this point, hopefully you found this presentation valuable. Gives you some good background information on what's going on out there in the marketplace at the state level, at the federal level, and hopefully at the local level too. And I think now we're going to open it up for some questions and answers.
Yes, thank you, Mike. This is Victoria from Wells Duffield, the Operations Manager for the Employee Benefits Department. We have several questions that have been submitted by the audience. As a reminder, if you have any questions that you have not submitted, please enter that in the Q&A or the chat box, and we will go through as many questions as time allows. So Mike, first question here. Do you know if there are any other states that are also looking at a single payer system like New York State?
Great question. Well, I don't know if anyone, actually, I think it was back in 2011, Vermont did try to implement it. And in 2014, they abandoned the model just because of funding. There has been, and it could be more than this. This is just what I've read. There has been legislation introduced in Colorado and Washington for a single payer as well. Where that stands, the political climate, I don't have an opinion on that, but I do know it has been introduced there at those two states as well. So, and I'm guessing there's probably a few other states that are, you know, have bills or concepts that have been kicked around, just hasn't got to the floor.
Okay. Another question. In defense of the hospitals, they need the profit from the private insurers to make up for the Medicaid shortfalls. Mm-hmm. How do we fix that?
Yeah, and that's what, you know, I'm today. I just want to deliver information. I don't have an opinion on, is it the, you know, the carriers, the hospital, the providers, who's at fault. You know, the bottom line is the whole system does need review. So that's the biggest question right now, because actually, you know, and I off the top of my head, I think I saw where one of the things that President Biden referred to was that there was over 139 rural hospitals that closed in the last 10 years, 19 in this past year. So that concern is very real. That you know, we need our hospitals. And what's interesting, can you imagine if we didn't have our hospitals system that we have now through this pandemic? You know, everyone worries about capacity, and you know, 5-10 years ago, we used to talk about like, oh yeah, but do we need this many beds? Do we need this many hospitals? Well, you know, guess what? It was nice to have that type of support. But in answer to how to fund that, you know, I think long term, it is some type of federally regulated arbitration, where carriers and providers come to the table with data to establish their position. And this is Mike Connery's opinion. I don't know what the perfect solution is, but I do believe that it's a combination of federal oversight with private and combining those two pieces. And one of the areas that the federal government and they're under the CAA, they're digging into this. I mean, under the No Surprise Act, there is provisions that eventually there'll be arbitration between providers and TPAs and carriers. And I think that's the key. And basically carriers and hospitals need to be held to those guidelines and those reimbursement models to make sure they are chasing waste out of the system as much as possible. But I don't have a perfect answer, just so you know.
Okay, one more question. Where has Walsh invested to help your clients navigate the topics you talked about today? As we all know, they are ever changing.
Mm-hmm. And I know a lot of folks in the Western marketplace, if you've ever dealt with me, you'll know that understanding the data is critical. Immediately I joined the organization, I said, we need to hire more individuals that can do the data analytics. We recently brought on 2 individuals that have bachelors in mathematics. It's really understanding the data. I mean, a consulting firm, especially when you get to the larger groups, we've moved from selling policies to understanding the data and understanding the opportunities out there to save money. And if you don't understand the data, you're kind of flying blind. So we're investing heavily in data analytics.
Okay. One more question came through. Anything we should be aware of in the pharmacy space? High cost drugs coming down the pipeline?
Great question. Actually, I see I'm at 48 minutes now, so it's good I didn't try to add a 5th topic. But my 5th topic was high cost pharmaceuticals. That is becoming a bigger and bigger driver in the healthcare cost continuum. And it's also, when you look at President Biden's executive order, he addressed 4 areas: hospitals, carriers, pharmaceutical, and hearing aids. And I didn't read a ton about hearing aids, just so you know. But in the pharmaceutical space, what's really driving it is obviously pharmaceutical companies, and when they have a patent on a drug, they can drive large margins. But it's the specialty drugs. And the gene therapy is something to keep an eye on. And the gene therapy drugs, it's only out there for a couple of conditions right now, FDA approved. But the expectation is it's going to go pretty far and wide in the next decade. And for example, one of these gene therapy drugs, it's $2 million. And, a lot of self-funded plans are just not designed to handle that type of cost. So there is the one thing that is only in the pipeline, it seems like, is just high-end specialties. And, if you're self-funded, that's the one area that, we certainly look at is specialty drug management. It's a critical component in your selection of PBMs.
Okay. Thank you, Mike. I'm going to turn it over to Chris to wrap up our session today.
Okay. Well, thank you very much. Thanks everyone for joining us for today's webinar. Mike, thanks. Thank you very much for sharing your insight, your expertise. We hope you enjoyed this presentation. Next week, we are looking forward to hosting Dr. Gail Burstein, the Commissioner of Health for the Erie County Department of Health, to discuss COVID-19 and any updates or impact the pandemic has had on our local business community. To register for Dr. Burstein's presentation and to view the rest of our lineup, again, please visit walshstuffield.com/summer school. And again, you do need to sign up for each class separately. If you have any additional questions or you would like to connect directly with the Walsh Stuffield team, feel free to reach out directly using the contact information on the slide. We are available to help with any of your employee benefits, well-being, or insurance needs. Again, thank you for joining us today and have a wonderful rest of your day. Take care, everybody. Thank you.
Thank you, everybody. Really appreciate it.